and I'll be helping you to complete this session. May I have the program sheet, please? Okay. अरे यार, इसे पढ़ने में बड़ी दिक्कत हो रही है, बहुत छोटा है. इसका निकाल दो. My God. लाइट भी इधर आ रही ना. E. Who's this?
Just ask that who you name.
The first and the second speakers, they have not given their. Rohit and Baba Sahab, they have not given their presentations. So, Parth Chaudhary? Parth, it is Parth?
Yes.
Oh yeah, it is Parth Chaudhary.
Well, Asim Taneja.
And following it would be Asim Taneja. Dr. Parth Chaudhary.
It's a slide change and I just give you a point. Good morning, chairpersons, my senior consultants, and my dear colleagues. The topic of my paper is a comparative study of intramedullary versus extramedullary plate fixation for treatment of intertrochanteric femoral fractures, a randomized clinical trial. According to recent studies, in 1990 there were 26% of all hip fractures which occurred in Asia, whereas this figure could rise to 37% in 2025 and to 45% in 2050. With advancing life expectancy and geriatric care, more patients who were conservatively treated in the past are now candidates for the surgery, and thus need for a study to better understand the intertrochanteric fractures and best possible mean to fix them. Due to high incidence of complications like malunion, implant failure, and a series of evolution in designing a perfect implant has begun. Only recently, a better understanding of the biology, reduction techniques, and biomechanically improved implants have allowed these fractures to be addressed with consistent success. This study was conducted in KLAS Dr. Prabhakar Kore Hospital, Belgaum, from January 2011 to December 2012. During this period, adult patients with intertrochanteric fractures of femur were classified according to Boyd and Griffin classification. 60 patients were included and randomized according to computer-generated random numbers. The anatomical results were classified as good or poor. A good result had no deformity, not more than 1 centimeter, shortening with good range of hip movements. A poor result had more than 1 centimeter shortening, fixed deformity, and limited hip movements. Functional results were assessed on the basis of Harris hip score. Inclusion criteria included age 18 years and older. Grade 3 and grade 4 only were included according to Boyd and Griffin classification. Medically fit patients for surgery and less than 2 weeks post-op. Exclusion criteria included grade 1 and 2, less than 18-year-old, previous surgery from proximal femoral fracture, pathological fractures, patient medically contraindicated for surgeries. Standard operative procedures was done. We preferred entry medial to the tip of the greater trochanter, and if anatomical close reduction was not possible, we did open reduction. This is a 51-year-old male patient with grade 3 IT fractures, which was pre-op and post-op images and 12-week follow-up images. This patient was treated, a 63-year-old male patient. This patient was treated with DHS, 12 weeks follow-up patient. Results, most of the patients were 61 years above and 32, and 41 to 60 were 24 patients. And majority of the mechanism of injury was fall on the side. Road traffic accident and fall from height were other two modes of injuries. And a majority of the cases were grade 3 of Boyd and Griffin. Delayed union was seen in PFN in 6 cases, shortening in 4, implant failure in 1, varus angulation in 2, Z effect in 2. The left X-ray shows Z effect, and the right X-ray, which is unusual complication on implant breakage of the proximal screw. In DHS, non-union was 0, delayed union was 4, implant failure in 4, varus malunion in 4, a shortening in 6 cases. This is one of the X-ray and after the removal of the implant. Anatomical results were almost similar in both PFN and DHS. Good in 22 in PFN and poor 8. Good in DHS 20 and 10 poor. Functional results, there were in PFN there were 12 excellent results as compared to 8 in DHS, while poor there were only 4 in PFN as compared to 6 in DHS. To summarize it all, the duration for surgery was more in DHS, and total blood loss, which included 48 hours of suction drainage, was more in DHS. Radiation exposure was more in DHS, and duration from day of surgery to mobilization was more in DHS, and duration for of stay in hospital was also significantly more in DHS. Shortening was a little bit higher in DHS. Coffer, Matthews and Sonstegard listed following variables as those that determine the strength of the fracture fragment implant assembly: bone quality, fragment geometry, reduction, implant design and implant placement. After these last 3 are in the hands of the surgeon, and out of that implant design, reduction and implant placement are depends on the experience of the surgeon, while implant design is for the surgeon to decide. According to a level 2B evidence, this is one of the initial study which was done in 1999, published in Injury. It showed that the results of this new implant compare favorably to currently available implants for the treatment of unstable pericontric femoral fractures. Another level 2A evidence, which was published in Clinical Orthopedics and Related Research, it showed that the low rates of femoral sharp fractures and failure of fixation suggest the proximal femoral nail is useful for treatment of unstable trochanteric and subtrochanteric fractures. Another level 2A evidence, which was published in Acta Orthopedica in 2003, showed PFN as an excellent implant for treatment of unstable fractures of proximal femur. And a recent study which was published in JBJS in 2013, a randomized control trial, level 1B evidence, their results suggest that the use of PFN in the treatment of trochanteric femoral fractures may have a positive effect on speed of restoration of walking when compared to the patients treated with DHS. As compared to other studies, in our studies, the bony union were almost similar to the other studies. Z effect was seen in 6.6% of the cases in our study. To conclude it all, osteosynthesis with PFN offers advantages of high rotational stability of the head-neck fragment, the possibility of static or dynamic distal locking, collapse at the fracture site, and is more biomechanically sound. Most of the complications are surgeons and instrument related. Proximal femoral nailing creates shorter lever arm, which translates to a lower bending moment and decreased rate of mechanical failure. The nails are load sharing implants, hence more mechanically sound. In our study, we found that PFN was superior to DHS in many ways, such as reduced intraoperative blood loss, lesser operative time, reduced radiation exposure, less amount of shortening, reduced hospital stay, lesser infection rates, early mobilization, and faster post-operative restoration of walking ability. Thank you.
Any questions?
Dr. Parth, in all your cases, you have used a short PFN nail.
Yes, short PFN,
But
sir.
in some of the cases, we have seen that there's a stress riser at the end of the nail.
Yes, sir.
So don't you think a long PFN is better option than the short PFN? And number two, if the middle cortex is comminuted, would like to put a graft in it in unstable fractures?
So, recent studies have shown that long PFN is in long PFN there are less incidences of femoral shaft fracture, periprosthetic fractures and anterior thigh pain, but we have not, in our study, we have not found any periprosthetic fracture. And the answer to your second question, sir,
Bone graft.
bone grafting, we have not done any bone grafting, although we have not seen any non-union in any of our cases. In delayed union cases, we have given protective weight bearing. And
Parth, just two queries. One, in the PFN that you have used, the proximal derotation screw is equal to the, in
no,
most of your X-rays, it was nearly equal to the distal locking screw. So I think that is not the right position. It has to be shorter, it has to be on a horizontal plane with the tip of the distal screw.
so we've seen 2 Z effect because of that.
Yeah, that is the reason of a Z effect. And secondly, have you ever tried the 18 centimeter short PFN?
18, 180, standard is 200,
Standard is 225 centimeters.
200, 180, 200 we have used, sir.
200 euros.
200.
Any questions from the audience? Thank you. The next speaker is Dr. Asim Taneja.
माउस लेके आना। माउस अब काम नहीं करता। क्या हुआ? माउस लगा दो 2 मिनट के लिए। नहीं। On this one and this is right change.
Thank you, Chairpersons, for giving me the opportunity to present my work on evaluation of results of intertrochanteric valgus osteotomy in ununited fracture neck of femur using various clinical criteria. As we all know that the standard treatment for fracture neck of femur in age group less than 55 years is internal fixation after anatomic reduction. This is associated with high incidence of complications, especially non-union and avascular necrosis, when the fracture is more than 3 weeks old. Arthroplasty is reserved only for stage 3 non-union, while osteosynthesis should be the aim in stage 1 and stage 2 non-union fractures. Options available to us are internal fixation with graft adjuncts like free or vascularized fibular graft or bone muscle pedicle graft. Another treatment option available to us is Powell subduction osteotomy. Valgus osteotomy has mechanical advantage as it converts the vertical shearing force to horizontal compressive forces at fracture size, hence the union is achieved by compression. Our study included 30 patients between the age group of 15 to 55 years. They were neglected femoral neck fractures more than 3 weeks, failed internal fixation, and fractures which failed to unite even after adequate internal fixation. Patients with radiographic signs of avascular necrosis, pathological fractures, or patients with disabling conditions were excluded from the study. Preoperative skeletal traction was applied only in neglected cases. In our study, we had 18 cases of subcapital fractures, 12 cases of transcervical fractures, 16 cases were Gardens type 4 and 14 cases were Gardens type 3 cases. We had no cases of Gardens type 1 and type 2. There were 28 cases in which the Powell angle was more than 50 degrees. Preoperative planning is very crucial to successfully perform this study. It includes size of wedge. The size of wedge was calculated. Our aim was to achieve the post-operative angle of 30 degrees or less so as to make the fracture line horizontal. The plate was placed in the inferior part of the femoral head to achieve the proper valgus positioning of the femoral head and allow the sitting of the blade plate onto the femoral shaft, as shown in this figure. The proximal limb of osteotomy should be perpendicular to the femoral shaft and should be 1.5 centimeter distal to the site of insertion of the chisel, so as to avoid the fracture of the lateral wall. Partial weight bearing was started after the union of osteotomy site, and full weight bearing was started once the fracture site union was observed. Clinical results were evaluated after 2 years of follow-up. The mean age of patients in our study was 40 years. We had 12 cases of failed internal fixation, while 18 cases were neglected fracture ranging from 4 to 65 weeks. We were able to achieve the average post-operative angle of 27 degrees. The osteotomy site united in all cases after 8 to 10 weeks, while fracture union was achieved in 26 cases between 20 to 26 weeks with average duration of 22 weeks. Harris score was assessed at 2 years of follow-up, showed excellent to good results in 80% cases with fair results in 2 cases. We were able to achieve the maximum score of 97 while the average score was 85. As per original Merle-D'Aubigné postal system, we were able to achieve the very good score in 10 cases, while 14 cases had good to medium results. 2 cases had fair results and 4 cases had poor results. The clinical results were also assessed on the basis of modified Merle-D'Aubigné postal system. In this, we had 16 patients which had good results, 10 had fair results, 4 cases had poor results. And as you can see, there was no patient which fell in the category of excellent result. This discrepancy was mainly due to the more strict criteria of grading of scoring in the range of motion of the hip. The radiograph on the left shows preoperative X-ray on the left of neglected femoral neck fracture, while on the right shows the union at osteotomy and fracture site. With addition, it was fixed with the double angle blade plate with additional cancellous screws. Radiograph on the left shows failed internal fixation of femoral neck fracture. On the right, it shows the union at the osteotomy and the fracture site.
Just half a minute more.
We encountered few complications with this procedure. The persistent non-union was seen in 2. The cause was likely to be the failure to achieve adequate valgus position of the femoral head. Avascular necrosis was seen in 4 cases, although the good functional outcome was observed in 2 cases and satisfactory result was seen in 1 case. Blade cut through and or joint penetration was seen in 2 cases. In 1 case, this complication was due to inappropriate placement of implant in the femoral head, and while in 2nd case, the patient was non-compliant and started to bear weight on the 2nd post-operative day. We were able to correct the average shortening from 2.7 centimeters to an average shortening to 1 centimeter. 10 cases had no limb length discrepancy, so this complication was taken as an advantage. Hence, with our study, we concluded that the position of the blade in the femoral head is very important, since proper angle will allow the closure of the osteotomy site and stable reduction. This procedure gave excellent to good results in 80% of cases. Patients with AVN can remain asymptomatic for longer duration if the union is achieved at the fracture site. The procedure, though technically demanding, is recommended to salvage the head of femur in where hemiarthroplasty is unwarranted. Or here are some references. Thank you.
Any questions? Sure.
question or comment, whatever you take it. It's about that your aim was to achieve the angle between the fracture and the horizontal line 30 degree or less than 30 degree, and you achieved 27 degree, all right?
Yes, sir.
Are you happy if you achieve the angle say 15 degree or 10 degrees?
So,
Yes or
no, sir. Further vulcanization of the femoral head will impair the blood supply and cause the abductor weakness.
Yeah, any other problem you can think of? Well, all right, that's why it is 30 to 35 degree, that's the most ideal, because lesser the angle, what happens, it will become almost horizontal.
And
neck
it will
and
can
this
cause
also.
further collapse.
Apart from the vascular compromise and the abductor weakness, there are so many other problems also. All right, so early development of the degenerative changes, because yours is not a long-term follow-up, and if you follow those cases where angle is less than 30, 20, 15 degrees, you will have very soon you will have the pain and the problem. All right?
Yes.
It will disturb
Very well
physically
taken.
everything. So don't achieve too less an angle also. 35 in my opinion is fine.
Thank you, Asim. Thank you. The next speaker is Dr. Latif Abdul.
This one. Respected Chairperson and delegates, I am presenting 7 years follow-up of transcervical osteotomy in fracture neck femur. As we all know, for neglected and non-innovative fracture neck femur, the treatment options for the patients below 60 to 65 years are either only fixation or with osteotomy and or with bone grafting. But all the available techniques have some significant drawbacks. In this context, we can remember James A. Dixon, who told it seemed desirable that a suitable operation be devised which would combine the advantages of corrected mechanics obtained by osteotomy with that of the improved osteogenesis produced by bone graft. Keeping in mind the principles of Professor Dixon, we have devised transcervical osteotomy, which is actually a trochanteric transcervical osteotomy. It combines the advantages of medial displacement of McMurray, the valgus angulation of Powell's, and the bone grafting of MPVG. Here, after proper reduction, the osteotomy starts at the level of vastus ridge, then along the neck of the femur, through within few millimeter of the inferior border of the neck up to the fracture site. The X-ray showing the left one showing the level of osteotomy, and the right one shows the status after displacement. After osteotomy, extraction is applied for easier medial displacement up to the periphery of the articular surface, along with abduction of about 45 to 60 degree. Then the extraction is released to achieve compression at the fracture site and at the osteotomy site. The figures on the left side shows the line of osteotomy, and the second one is after displacement, shows how it combines the abduction, the medial displacement, and the bone grafting. The fixation is done with modified Tupman plate. We have modified the Tupman plate by introducing a long continuous hole in the proximal, middle, and the distal limb, along with a variable length of the medial limb, like 0.5 centimeter, 1 centimeter, and 1.5 centimeter. This is the X-rays after fixation with two 6.5 cc screws for the fracture, with 2 to 3 cortical screws, and also a cortical or canceller screw for fixation of the greater trochanteric fragment after pulling it distally with a pointed reduction forceps to prevent the shortening of the abductor lever arm.
The inclusion criteria was non-union fracture neck femur less than 60 to 65 years of age, a Powell's grade 3 Garden 3-4 fracture neck femur with more than 2 to 3 weeks duration, and we have done in the fresh cases with vertical shear fracture of Powell's 3 fractures. The results, the study was from 2007 to 2013 with 50 patients treated with this osteotomy after proper informed consent. The post-op regime was bed rest for about 6 to 8 weeks, auxiliary crutch walking for 6 to 8 weeks, then elbow crutch walking was started for 4 to 6 weeks, and full weight bearing was allowed after 16 to 18 weeks. In follow-up, non-union developed in 1 patient, AVN occurs in 1 patient, cutout in 2 patients, shortening less than 1 centimeter in 5 patients. All united cases except 4 can walk without support with minimum pain. And all the united patients can squat, but our 50% with some difficulty. We have seen no significant effect of posterior comminution, and in the period of follow-up, no secondary weight changes developed. These are the results. This is one of the X-ray with non-union fracture neck femur. The left below inferior one is after follow-up. This has been done after failure of CHS. This is another X-ray. This is another follow-up. This is the 6th X-ray. Here we have used three cannulate cancellous screws for fixation of the fracture. This has been done after failure of McMurray's osteotomy with Wainwright plate. This is another one. This has been done after 1 year of non-union. This is the 11th one, and this is the last one. This has been done after 1.5 months of fracture in a 23-year-old male patient. The last X-ray shows up after union. And in discussion, the advantages of transurethral osteotomy as we are recommending, it combines the principles of McMurray's, Powell's and MPBG. The osteotomy is a stable one. Union is almost ensured. There is no minimal shortening, and the chances of AVN is less due to as a fracture hematoma is drained out as in fresh cases, so the tamponade effect is less. Second one is the distal osteotomy fragment is a raw vascularized bleeding surface that will act like MPBG, and the C is that is maximum medulla to medulla contact, which will increase the chances of revascularization following fixation, and there should be no problem with future THR. In conclusion, the facts regarding the fracture neck femur still are: the union rate in non-united fracture neck femur with abduction osteotomy is about 80 to 90%. The non-union is still 10 to 20%, and AVN is still about 20 to 40%. With a shortening more than 5 centimeter is about 66%, whereas more than 5 degree is about 39%. And still the ideal fixation device remains undefined for the fracture Powell's 3 vertical fracture neck femur. And in young patients, the rate of AVN and non-union is still higher. In this context, this osteotomy with low rates of complications may be suggested to decrease the non-union, shortening, varus and AVN of the unsolved fracture of neck femur. And lastly, may I suggest this as a good alternative in fresh displaced fracture neck femur. Thank you.
Thank you, Dr. Latif. Any questions, please?
Yes, sir.
Have you done any THR in post in AVN cases?
I have done one case developed avascular necrosis, and I have done hemiarthroplasty in that case.
Which implant?
Yes,
Which implant did you use?
I have done this transurethral osteotomy.
Processes.
Bipolar procedure.
Yeah, I'm Dr. Chinwal. You have shown two cases which have gone cut out.
Yes, sir.
What did you done next?
We have done hemiarthroplasty.
Hemiarthroplasty.
Yes, sir.
You are recommending in fresh cases also, the osteotomy is good in displaced fractures.
Yes, sir.
Also, palliative screw fixation, you can use the fracture well. Is also good. So why to operate this osteotomy in fresh fractures?
No, I am just suggesting. I am not definitively telling this. Where you are, I am proposing this, where you are doing osteotomy, instead of parallels, do this and will get good result.
Thank you, Latif. And before I call next speaker, Biswajit Das, this is news for you. Arvind Kejriwal is leading against Sheila Dikshit.
And with a landslide victory for the party. Well, Aam Aadmi Party, yeah. Number one. More than 50% seats. The last speaker on this session is Dr. Biswajit Das.
अब इसमें क्या हो गया, फिर हैंग हो गया था, माउस का तो काम नहीं ना फिलहाल आपको. Just slide change.
Good morning everybody, myself Dr. Biswajit Das and my presentation is management of tibial plateau fracture by different treatment modalities and observation. Tibial plateau fracture involve proximal articular surface of tibia. The major causes being RTA, fall from height and athletic injuries. It results from a combination of axial loading with varus or valgus force. The Sachs classification is the most widely accepted classification for this, and it contains type 1 to type 6 types of fractures. In 1930s, initially it was treated with plaster casts and brace. In 50s, the open reduction and internal fixation started, and later in 1980s, with improvement of surgical technique and implants, the surgical techniques also improved. Despite many advances in the care of intra-articular fractures, tibial plateau fracture continue to remain a very difficult surgical problem. So purpose of our study was to evaluate different modalities of treatment of tibial plateau fracture and the role of early mobilization and achieving a stable and functional knee. Aims and objectives were restoration of articular congruity of tibial condyle, maintenance of axial alignment, preservation of a functional pain-free range of motion. Total 44 patients were included with mean age of 34.6 years from 2011 to 2013, and majority of the cases were RTA. So patients with compound tibial plateau fracture or patients having compartment syndrome at the presentation time or patients with polytrauma were excluded from the study. Out of 44 cases, 12 cases were treated conservatively and 32 were surgically treated. Conservative treatment was done in case of undisplaced or minimally displaced fractures or the patients who are medically incapable of withstanding surgery. So in conservative treatment, podcast was done after reduction for 4 weeks. Then it was maintained with functional knee braces, and then at 8 to 10 weeks partial weight bearing was started, and at 12 to 16 weeks complete weight bearing was done. Also another type of method was the distal tibial skeletal traction was done in 2 patients only. For 3 to 4 weeks it was maintained, then at podcast was done at 3 to 4 weeks for 8 years maintained, and again at 6 to 8 weeks hinged knee brace was applied, and 10 to 12 weeks partial weight bearing was started and gradually progressed to full weight bearing. Out of 32 cases who are managed surgically, in 6 cases percutaneous cancellous screw fixation was done, in 5 cases ORIF with cancellous screw was done, in 12 cases ORIF with buttress plating, and in another 5 cases ORIF with locking plating was done. In rest 4 cases MIPO was done. These are few interpretive photos. In this case under C-arm guidance, cancellous screw is being applied to fix the fracture percutaneously, and in this case open reduction and internal fixation with cancellous screw is being done. Another case where open reduction and internal fixation with buttress plate and bone graft is being done. and here with locking plate the fracture is being fixed, and in this case MIPO technique is applied to fix the fracture. So post-operative follow-up, the patients were mobilized after 48 hours post-operatively. From 2 to 5 days, the range of motion was allowed 0 to 20 degree. From 5th day onwards, range of motion was gradually increased up to 90 degree or more. After suture removal, full range of motion was allowed. At 6 to 8 weeks, partial weight bearing was done, and at 12 weeks, full weight bearing started. Observation: all fractures united within expected time. No case of non-union was noted. The average time of union was 14 weeks, the range being 12 to 12 weeks. So this is the table that shows most of the fractures, that is 63%, that united in 10 to 14 weeks. And this shows the complication. In the conservative group, the knee stiffness was most common, and in the operative group, it was the post-traumatic osteoarthritis was the most common complication. So results: the clinical outcome was evaluated using Lassinger criteria that contains pain, working capacity, extension of leg, range of motion and stability, and they were graded as excellent, good, fair or poor results according to the points. This shows the results. In the surgical treated group, 13 patients has excellent result and 15 has good result. In the conservative group, 3 patients has excellent and 5 patients has good result. These are the few clinical follow-up cases. This patient managed conservatively, and at 3-month follow-up he is seen. And this patient managed with cancellous screw, and at 3-month follow-up the patient is seen. And in the case 3, patient managed with buttress plate, and at 3-month follow-up the patient is bearing weight. And another case, that is in patient managed with MIPO technique, and at the 3-month follow-up patient is showing the range of motion and weight bearing. So discussion: in the surgically treated group, 43% got excellent result and 46 has good result, and in the conservative group, 25% has excellent result and 42% has good result. Retrospectively, it was found that high velocity injuries, that is type 4 to type 6, have poorer outcome than lower velocity injuries, and these high velocity injury cases account for 6 cases out of 8 combined poor and fair outcomes in our present study. So conclusion: management of tibial plateau fracture is challenging, and it needs excellent anatomical reduction and rigid fixation to restore the articular congruity and to facilitate early knee motion, thereby reducing post-traumatic osteoarthritis and thus achieving optimal knee function. But recent trend is to do minimal invasive surgeries possible. Many centers have shown good results with arthroscopic assisted internal fixation, hybrid external fixator, minimal internal fixation supplemented with external fixation, or Ilizaros ring fixation. We have not employed any of these techniques, but still we got satisfactory result with the standard conventional methods. Thank you.
Thank you, Dr. Das. Any questions, please? Thank you. That brings us to the end of this session. I would request Dr. A.N. Verma to kindly chair and moderate this session.
Good morning, everyone. We now come to the session of chondroprotective drugs. May I call upon the first speaker, Dr. Ashok Vij, to speak on chondroprotective drugs.
Yeah, may I add over here? This is not a talk, this is a debate. Dr. Ashok Vij is speaking for against, no?
For the motion.
For, and Dr. Atul Bahadur against. And the end of the session, the questions can be asked from either of them, and let's see who speaks strongly for their subjects.
I am prepared to fight tooth and nail for the debate. Clicks here, no? Well, gentlemen, the debate is on the chondroprotective drugs are not useful in osteoarthritis knee. For me, it is a statement. It's not a question. Osteoarthritis, I know that every one of you knows that it's a degenerative joint disease. But putting up a definition for a chondroprotective drug, it's a specific compound. It has to be a specific compound or chemical that delays progressive joint space narrowing, characteristic of arthritis, and improves the biomechanics of articular joints by protecting the chondrocytes. Now, the drugs commonly in use these days are the hyaluronic acid, glucosamine, chondroitin sulfate, S-adenosine methionine, also known as SAMI, collagen hydrolysate powders, and diacerine. We'll be talking mainly on these drugs. A short intro to these drugs. This is the simplest one, which is more common, claims to lubricate and cushions your joint and gives nutrition to the cartilage. The SAMI also, what's this happening? This also contributes to the building blocks for cartilage. These are claims considers, it could be a new ally in the battle against the pain of osteoarthritis and fibromyalgia that they say. Now, what is the collagen hydrolysate? It's claimed to be a bioactive collagen peptides, and the role is for the collagen synthesis. This the chart that shows how it works, but this is not my concern today. Glucosamine, it is an monosaccharide, and the synthesis of it stimulates the synthesis of proteoglycans and collagen by chondrocytes, and that is what is claimed. It has mild anti-inflammatory activity. Another drug which is commonly being used these days is chondroitin sulfate, most abundant glycosaminoglycan in articular cartilage, and it inhibits the degrading enzymes. These two drugs have been used more in synergy rather than alone, and the research with cell structure and animal models using a patented combination of glucosamine, hydrochloride, and chondroitin sulfate has supported their use in synergy. Now, what is my case? This study, evidence-based practice, a review of clinical evidence on the efficacy of glucosamine and chondroitin in the treatment of osteoarthritis, shows that the GATE study, which is known as the GATE study, conducted in the US by the National Survey, the GATE results showed that the glucosamine and chondroitin sulfate were not effective in reducing knee pain in the study. However, these may be effective in combination for patients with moderate to severe knee pain. In another study, it's the same, the GATE trial, and this trial showed that glucosamine, hydrochloride, and chondroitin sulfate alone or in combination did not reduce pain effectively in the overall group of patients with OA of the knee. Now, a review of evidence-based medicine for glucosamine and chondroitin sulfate use in knee osteoarthritis. The literature satisfying our inclusion criteria, glucosamine sulfate, glucosamine hydrochloride, and chondroitin sulfate have individually shown inconsistent efficacy in decreasing OA pain and improving joint function. Many studies confirmed OA pain relief with glucosamine and chondroitin sulfate use. This is a meta-analysis. Now, another study, the clinical efficacy and safety of glucosamine and chondroitin sulfate, their combination, celecoxib, placebo, it's a 2-year results from the GATE. The conclusion is that over 2 years, no treatment achieved a clinical important difference in the OMAC pain or function as compared with placebo. Now, this is what is important. Adverse reactions were similar among the treatment groups, and serious adverse events were rare for all treatments. Arthritis Rheumatology Journal, the effect of glucosamine or chondroitin sulfate on the progression of knee osteoarthritis. The conclusion is that at 2 years, no treatment achieved a predefined threshold of clinically important difference in the GS joint space loss as compared with placebo. However, knees with grade 2 radiography OA appear to have the greatest potential for modification by these treatments. Now, the study, the clinical effectiveness of glucosamine chondroitin supplements. There was evidence that glucosamine sulfate shows some clinical effectiveness in the treatment of OA of the knee. Now, this is what I wish to draw your attention to. This is the ortho info of the AOS website for the public domain. And they say that the hope and the hype, they discuss that people who use these nutritional supplements hope that they will relieve the pain, perhaps even repair or restore the joint cup. But there is no proof that either substance taken singly or in combination will actually slow the degenerative process or restore cartilage in arthritic joints. And this is what the AOS has to say to their people. And dietary supplements are not tested, or now this is where caution is required. Dietary supplements like glucosamine and chondroitin sulfate are not tested or analyzed by the FDA before they are sold to consumers, because they are being sold as food supplements. That means consumers can't be sure they are getting what they pay for when they purchase bottles labeled glucosamine chondroitin. In fact, a recent study by Consumer Lab.com showed that almost half of the glucosamine supplements tested did not contain the labeled amount of ingredients. And that is why they say don't stop your regular medicines, consult your doctor and do some research. Now, another study, comparative clinical trial of SAMI. This concludes that this study found no significant differences in pain relief or tolerability between treatment with SAMI or nebumetone over 8 weeks in Korean patients. About diasterin, the Cochrane database review says that there is a gold level evidence that diasterin has a small consistent benefit in improvement of pain. Further research is necessary to confirm the short and long term effectiveness. This study, the recent one, it says that about the efficacy of diacetyl in osteoarthritis. Now, 86 Korean patients were enrolled. The intention to treat and per protocol analysis revealed that no significant differences between the two groups in terms of change in Oscar pain score was at 4 weeks. The efficacy and safety of diacetyl in the treatment of painful knee. The objective was to determine whether the efficacy of diacetyl persists at 2 months after the 3 months period. And the conclusion is that this is the first published study of a symptomatic slow-acting OA, and the results showed that diacetyl was safe and effective, and the effect lasted for another 2 months extra. Now, this study concludes that the intra-articular hyaluronic acid was superior to placebo in improving knee pain and function, with no difference between 3 or 6 consecutive injections for the primary efficacy assessment. So, gentlemen, are we able to form any opinion till today? The issues are still confusing. The evidence still not very definitive. We have to cope with external pressures, hope of the patients, and above all, scope of the industry, the industrial pressures. So, do we succumb or do we stand tall? As of today, I would like to stand tall. The path is foggy. As the mist clears, we would visualize better. And that's all. Thank you.
Thank you, Dr. Vij. Now may I call upon Dr. Atul Bahadur Singh to speak for the chondroprotective drugs. Against the chondroprotective drugs. Sorry.
No, I have to speak against that. They don't.
Yeah. Against the motion.
I have to speak that they are useful.
Yeah. That's what I said for the chondroprotective drugs.
So this is a slide change here. This is a point.
Mr. Chairperson and the delegates, chondroprotective drugs are useful for osteoarthritis of the knee. As has been highlighted by Dr. Vij, that OA has multiple influences, and there are a lot of work which is available to show whether the chondroprotective drugs act or no. The 4 goals of treatment are to control pain, to improve joint function, to maintain normal body weight, and to achieve a healthy lifestyle. These would be an ideal disease modifying osteoarthritis drugs where what they need to do is delay structural progression, prevent the OA, halting progression, improving the X-ray, reversing progression, normalizing the X-ray. How they need to do is effect on progression of the control of joint space narrowing and pain and function relation. Chondropredictive drugs, as also highlighted by him, are the same which are available in the market. Of glucosamine, the better salt is glucosamine sulfate, because it has been documented that glucosamine hydrochloride has no action. Chondroprotective drugs, as the name suggests, are useful in the biosynthetic phase or till there is cartilage to protect. That means early osteoarthritis, Kellgren-Lawrence grading scale 1 and maybe in 2. They have to be used for long durations for optimum benefit. Gap therapy is possible as in dicerine. Once mechanical defect has set in, even NSAIDs provide symptomatic relief only. OA is characterized by two phases: the biosynthetic phase, where there is repair going on, and second is the degradative phase, where activity of enzymes produced by chondrocytes digest the matrix and matrix synthesis is inhibited. So the cartilage is being eroded. These are the recommendations of the Osteoarthritis Research Society International, which point 18 says treatment with glucosamine and or chondroitin sulfate may provide symptomatic benefit in patients with knee osteoarthritis. If no response is apparent within 6 months, treatment should be discontinued. The second 19 being, in patients with symptomatic knee OA, glucosamine sulfate and chondroitin sulfate may have structure modifying effects, while dicerine may have structure modifying effects in patients with symptomatic OA of the hip. Here are some interesting facts about osteoarthritis. Every year 2 million adults visit the GPs because of OA. These are papers from US. 15% of all musculoskeletal consultations in those aged 45 and old, over 5% have an osteoarthritis recorded primary care consultation. This peaks at 25% in those aged 75% or old. Of these, 10% have osteoarthritis. Incidence of new GP consultation for knee pain in adult aged 50 and over is approximately 10% per year. Over a year period, there are 1,14,500 hospital admissions, and in 2000, 35,000 knee replacements were done, costing a huge sum of money. These are some interesting facts about X-rays, because osteoarthritis is a very gray area where you have no diagnostic means. Half of adults aged 50 years and over with radiographic osteoarthritis of knee have symptoms. Of the 25% of older adults with significant knee joint pain, 2/3 have radiographic disease. The prevalence of painful disabling radiographic knee osteoarthritis in UK population aged over 55 has been estimated at approximately 10%. The prevalence of symptomatic radiographic osteoarthritis is higher in women than men, especially after the age of 50. Within the knee joint of symptomatic individuals, the most common radiographic osteoarthritis pattern of involvement is combined tibiofemoral and patellofemoral changes. Knee osteoarthritis is very variable in its outcome. Improvement in the structure of joint as shown by radiographs is rare once the condition has become established. However, improvement in pain and disability over time is common. The data on clinical outcome as opposed to radiographic changes are sparse, but it would seem that over a period of several years, a third of the cases improve, a third remain much the same, and the remaining third of the patients develop progressive symptomatic disease. Little is known about the risk factors of progression, which may be different from those of initiation of the disease, but obesity probably makes an important contribution. This is one of our treatment guidelines where we start from non-pharmacological to pharmacological and finally to surgery on the severity of the osteoarthritis. This is an interesting data picked up from the web. In 1960, the average expectancy of the Indian life was 42. Now it has come to 65.48 in 2011. This will increase over the years. Hip and hand osteoarthritis is rarely seen in India. Knee osteoarthritis cases are set to rise exponentially with no clear guidelines or investigation profile for diagnosis of treatment or protocol will remain empirical. Pain in osteoarthritis is a protective mechanism, so overuse of NSAIDs is detrimental. Inflammation is a response to the disease and not the cause of the disease. Anti-inflammatory reduce pain in the brain, not at the knee. Once biomechanics has changed, even as NSAIDs give symptomatic relief, Indians still abhor invasive treatment. Literature still lays great importance on conservative treatment modalities. Here the chondroprotective drugs will be the mainstay of treatment in early osteoarthritis. Future of the drugs are bright, as the dictum says, an ounce of prevention is better than a pound of cure, is still here to stay. Chondroprotective action of NSAID is now an issue of interest in a paper which was published in '89, and others are also coming up. In the marketing parlance, nothing succeeds like success. Till chondroprotective drugs, whether as OTC in the US of A or as drugs, continue to sell and the market continues to grow, the message is clear that they do work. Mechanism of action relief is still poorly understood. Finally, we have miles to go before we fully understand the development of primary osteoarthritis, develop modalities for early diagnosis of osteoarthritis, have a diagnostic non-invasive test for osteoarthritis. NSAIDs only provide symptomatic relief and are not curative, so a multimodal approach to the treatment is must. Thanks.
Atul Bahadur Singh. Any questions, the two speakers?
I'll say both of you protected your subject very well, and as one could see that they really did very hard work, because the search in the literature and what was shown was very extensive and massive by both of you. So I'll say very well done. And certainly at the end, because I could see only 4 or 5 delegates over there, and what I'll request that each one of you is going to give your comment or question or anything like that. Every one of you. So starting from you, every one of you.
Myself, President from Pune. So I want to know, there was a short note last year in my college for MS appearing in preliminary examination, the prolotherapy, in which the injections were these disease-modifying osteoarthritic drugs were given in the injection form in the knee. So I want to know what should I write in prolotherapy or short note form.
See, as far as the injections are going on, there are two kinds of injections available in the market, the short-term one and now the with the greater Dalton effect, the single injection form, as well as now the recent studies are being on for the PRP, for the platelet-rich plasma being injected in the knees. So these are the several forms available now.
So can these disease-modifying osteoarthritic drugs can be given in injection form in the knee? In what dosage, if yes?
No.
No, they have not been tried as yet.
These may be experimental things, but they are not being practiced. Yeah.
Any chondroprotective drug or DMARDs act when they are used early in osteoarthritis. Once the mechanical defect has set in, there is nothing you can do. It is only prior to that mechanical defect.
Is that right, what is said? Dr. Viz, you agree?
Sir, I have just one submission to make. I have presented before the chair evidences. What Dr. Atul has presented are the details of osteoarthritis disease. No evidence has been presented for the chondroprotective drugs.
Yes.
So, I win.
Yes. Please use the mic. Please use the mic.
Hello, sir.
Speak some question.
Hello, sir. Myself, Dr. Raviraj from Bangalore, Karnataka. Both the talks by both sirs were excellent. Particularly given by which sir was really good, sir. So I just want to ask sir that sir has clearly told that glucosamine and chondroitin sulfate has no advantage when compared to diacerin. So my question to sir is, what do you feel whether chondroitin sulfate and glucosamine is better when compared to diacerin? I'm seeing in terms of when we use in early stages only. Which one do you feel is the better one?
See, the use of diacerin is compared to glucosamine and chondroitin is very new. And the other thing is this, that the world literature which is available as of now, diacerin has been used more extensively in hip osteoarthritis. We in India rarely encounter primary hip osteoarthritis or osteoarthritis of the hands. So empirically it is being used, but today we have no documentation or no meta studies to show which is better. But because of the experience people have over the period of time with glucosamine and chondroitin, they are being used more frequently. And diacerin, having been launched, is being used by us. But the benefit in diacerin is you have that benefit of gap therapy where it works. You can stop it for a period of time, then re-continue.
Sir, my question to Vij sir again.
Before you ask that question, I would like to put in my case here. See, glucosamine and chondroitin have been in use for the last 20 years as food supplements. Why, with the infrastructure available in the US, it has not been projected, not been available to get permission as a drug? Why couldn't it produce any evidence to to present that there was any improvement in the cartilage? Why? Because it is not. So, it is not useful.
So my simple question to Vij sir again. Sir, do you prescribe diacerin to your patients with osteoarthritis?
Amongst all these things, personally, I have used SAMI for some time, but the overall effect in the long term was no good. So I stopped using it. Chondroitin sulfate I have never used in my life.